For calling. Well, guys, today I'm going to be talking about the cranial nerve number 12, the hypoglossus nerve, and I'm going to be talking a little bit about the anatomy, the pathology, some mnemonics, and some quizzes. So basically, guys, what's going to be happening over here, guys, we're going to today be talking a little bit about the anatomy of cranial nerve number 12. Cranial number 12, it comes from the medulla, so we have three parts of the brainstem here illustrated: midbrain, pons, medulla, and the cranial number 12 comes from the medulla, and it comes from the medial parts. There are two nucleus sitting here. Next to it be dorsal nucleus vagus, and next to it be nucleus structus solitarius. But there are two fibers that go in and they go through these red things. These red things are the hypoglossus canal, and this allows the nerve to exit from the spine and exit from the cranium as per se, and then enter the and go towards the tongue, towards the muscles of the tongue. So it goes into the intrinsic muscles and then the extrinsic muscles of the tongue. So I'm going to be speaking a lot of detail about the extrinsic muscles of the tongue in the next slide, but intrinsic muscles of the tongue, I'm going to diving into the details right now. So over here, guys, we have two main superior longitudinal muscle and inferior longitudinal muscle, and then we have a vertical muscle, and then on top of that we have a transverse muscle. So all of these muscles make up the intrinsic muscles of the tongue. What about the extrinsic muscles of the tongue? So extrinsic muscles of the tongue, well, basically what happens is that we're going to be having three main big bad boys over here. So this is going to be our intrinsic muscle of the tongue we see in our mouth, in our oral cavity. But over here we have the styloid process, which is connected to our temporal bone, which I have not drawn over here. So the styloglossus muscle, and then the hypoglossus muscle, so for anything underneath going towards the tongue, and then genioglossus muscles. All of these glossal muscles, intrinsic muscles, are supplied by the tongue. Very key information that we need to mention over here. The next thing is going to be anatomy. What is the anatomy? So basically, the anatomy over here is that the cranial number 12, it exits the skull through the hypoglossus canal, and this hypoglossus canal is going to be located in the occipital medially and superiorly to the occipital condyle. So this occipital condyle kind of here and here. So these two bad boys are going to be very medially and also superiorly. Then what about the pathology of the cranial nerve number 12? So what is going to be the pathology of cranial number 12? The cranial number 12 pathology is going to be that we're going to be first of all having that there's going to be lower motor and upper motor neuron lesions. So lower motor neuron lesion is quite simple, that is peripheral to the brainstem, and therefore it is ipsilateral. So what does that mean? So if this is the precentral gyrus, and this is going to be the medulla, and this is going to be our intrinsic and extrinsic muscles of the tongue. So over here we're going to be having two nerve fibers, both of which are going to be crossing, and then from here the fibers will continue ipsilaterally. Oops, sorry. The two fibers will be continuing ipsilaterally. So that's really an important key that I need to mention here, that both fibers are continuing ipsilaterally towards the tongue. So any sort of damage in the right fibers would lead to a pathology on the right side. Any type of damage in the left side would lead to a pathology on the left side. The upper motor neuron is a bit more tricky. They're from the cortex, so speech and regard is the cortex, and they're contralateral deviation. So if I get a problem with my left, let me just re-illustrate that for you guys, so that we're on the same page. I'll make it in red so we know where we're going with this. Sorry, one second. So let's just say, okay, I have a really big pathology over here. Okay, let's just say I have a really big pathology over here, and it's compressing this really big nerve over here. So then what happens is that when it compresses this type of nerve, then where will the pathology be? So if it compresses this nerve ipsilaterally, then the pathology will also be ipsilateral. So we're going to be getting the pathology on the side of the tongue. But if let's just say it goes and compresses compresses this part of the fibers, then the pathology will be on the contralateral side. So if affects the right fibers, will be on the left side of the tongue. So these pathologies manifest as atrophy fasciculations. We'll talk about that in detail in the next slides. So like I was saying, if there's a unilateral lesion, so unilateral means that only one of these fibers are going to be damaged. So if there's a unilateral lesion, then the ipsilateral half, so the same side half it'll become atrophic, and it'll be paretic. So paretic means that there's going to be a lack of movement. Paretic And there'll be fasciculations can occur. The tongue lying quite quietly in the mouth would deviate to the intact side, and when protruded, and it deviates to the paretic side. So whenever this person sticks his tongue out, his tongue will kind of and let's just say, okay, so unilateral peripheral lesion, if we have it over here, problems with this part of the tongue. So when we tell him to stick out his tongue will stick out, but it will be deviated towards this side. His tongue will stick out to this side, and all the problems will be occurring on the right side of the tongue. So that's really, really important. A central lesion, there's going to be mild unilateral weakness, but there will be no atrophy. So there's going to be very little amount of atrophy. Like a central lesion, again, let's just say central lesion of the left side. So that means let's say the right side. So that means the problems will obviously be on the left side. So we'll go over here, and it'll be very little atrophy over here. You can see that it'll be more. There won't be really much atrophy, very little. And then the problems will be on the left side. So if there is any atrophy, will be very few on the left side. So that's how this tongue will be sticking out. Then we'll go into the bilateral lesions. Bilateral lesions, it's very hard to protrude the tongue. And we're going to be getting symptoms of dysarthria, because dysarthria means any sort of problems with articulation or muscle movement. So when we have, and obviously the tongue, like we just spoke about, is made out of loads of muscles, so we can get this problem. We can get this type of problem with atrophy fasciculations. This is going to be seen in bulbar palsy, and this is going to be progressive loss in the motor neurons of the cranial 12 and the medulla. And then surbulbar is going to be ischemia of the central bulbar fibers. What's going on here? So basically, let's just say I get a bilateral lesion. So I get a lesion of both of those two peripheral nerves. So what's going to be the manifestation? So first of all, the manifestation of the tongue is that first of all, it won't be able to stick out. So I'll just draw this tongue that it'll be very small. It won't be able to stick out. So it'll be very hard. And whenever we ask him to speak, he'll have dysarthria, so he'll have problems with speaking. And again, he'll have fasciculations, atrophy, weakness of the tongue. Then pseudobulbar is going to be a problem of our central nervous system. So our central nervous system over here, pseudobulbar, what's going to be the problems over here? So pseudobulbar is going to be problems over here. I can delete this. Again, same problems. We cannot stick this tongue out. Probably the main way to differentiate peripheral and this will be that there's no paresis, there's no atrophy, and there's no amount of fasciculations. So that's a really key. So no atrophy, weakness, and no amount of fasciculations. Examination of the cranium number 12, again, tell them to protrude the tongue out, and if it's normal, it'll be in the midline. If it's pathological and it's peripheral, it will deviate to one side. Atrophy or not, so that atrophy or not kind of tells us whether it's central or not, or peripheral, and fasciculations if they're there or not. A quick, I want to talk a little bit about the causes of pathologies. Okay, so central lesions would obviously be a stroke which is occurring in the motor cortex, and a peripheral lesions would be maybe some sort of it can easily be like some sort of so any causes so central lesions which are going to be unilateral. Lateral can be stroke, and then in the motor cortex, and there can be, if it's unilateral, peripheral lesions. It can be due to any sort of problems of the peripheral lesions. So it can mess up any sort of fibers that is going to be there. So it can for example, it can lead to any sort of brainstem stroke can be there, which can, if it's affecting it, maybe some sort of tumor that can compress the nerve fibers, or some sort of or some sort of inflammation that can occur there. But one other one I really want to mention is going to be internal carotid artery aneurysm, So kind of to explain this, what I first want to draw for you guys is going to be the brainstem. So I'm not going to be really speaking about the cortical. I'm not going to be speaking about the central pathways, because like I said, it's going to be a peripheral problem. So if I were to draw this as a brainstem, and like I said, it comes from the medulla and it goes from the central part. So I'll quickly, no, sorry, I'll quickly, I'll quickly. Quickly draw these nerve fibers coming out. Obviously, there are two nerve fibers, but I think for simplicity's sake, I will just draw like one nerve fibers, and one nerve fibers, and essentially this nerve fibers, it goes through the internal and external carotid artery. So these two nerve fibers, they are going to be going through the internal and the external carotid artery. So if we draw this, let's just say this is going to be our internal, okay, but let's just say this is external, and then on the back side I can draw the, I can just order it, put it towards, send towards the backwards, send towards backwards, send, wait one second, okay, order frontwards. Okay, perfect. So we can see then the cranial nerve number 12 is kind of going through this. So what happens is, if this, like this, the internal, this external, or whatever, whichever one it is, internal or external. So this one's outside, so external, and this one's internal. So if there's going to be an aneurysm on this, it can kind of compress the nerve, and that can lead to a big problem. And obviously, the nerve comes out. It obviously, like I didn't draw it, but it goes to the hypoglossal canal. So I'll draw the hypoglossal canal over here. I'll draw the canal in red, in red, it's going between the internal and external carotid artery, and then from here it's going to be going to the glossal muscles, so intrinsic, external glossal muscles. So on the way, if the aneurysm compresses it, that can be a big problem. Bilateral, what are the causes of bilateral, central and peripheral? Central lesions bilaterally, it can be, for example, central lesion, any sort of central lesion bilateral can be due to the fact that there can be pseudobulbar palsy, so pseudobulbar palsy, and this type of pseudobulbar palsy that is going to be there is going to be like, for example, obviously stroke of the brain. It can be due to MS, multiple sclerosis. It can be due to stroke of the brain, MS. It can be due to any sort of central nervous problem, central nervous CNS problem, and then obviously peripheral lesion, which is going to be bulbar palsy. So any causes of bulbar palsy will fit in here. So well, okay, we can also get like osmotic pontine myelinolysis. Osmotic pontine, I don't know whether pontine would fit here, but if there's going to be some sort of osmotic fluid which is there, it would kind of lead to the death of the myelin sheaths, and that could possibly lead to a problem over here. Stroke of the brain, MS, bulbar palsy can be there. So bulbar palsy can be obviously a big one, big GBS, brain stem stroke, maybe some sort of trauma, any sort of bulbar palsy which kind of causes bilateral problems. So I believe Amos they have a beautiful table for bulbar palsy, so I really recommend seeing that. Summary, very quick summary. Hypoglossal, and actually I don't think I'll be giving you guys a summary because it's a very small topic. I'll quickly guys give you a quiz and the mnemonic. Yeah, I forgot to mention mnemonic. The way to mnemonic is going to be for the intrinsic muscles, and that's going to be intrinsic muscles of the tongue, okay, so the intrinsic muscle of the tongue can be obviously we know we call it hypoglossal muscle, hypoglossal nerve, right? So so how would it be? Hypoglossus muscle, hypoglossus, and then genioglossus muscle, and then styloglossus muscle. So you can see over here the H is going to be repeating over here, the G is going to be repeating over here, the S is going to be repeating over here. Hypo, geno, stylo. Quiz time, quick quiz. How does cranial number 12 leave the skull? So answer is going to be hypoglossal canal. Can you name for no, by the way, this mnemonic was for extrinsic. Extrinsic muscles of the tongue. Can you name 4 intrinsic muscles of the tongue? Sure, why not? Superficial longitudinal muscle, inferior longitudinal muscle, transverse muscle, and horizontal muscle. Can you give me a cause, or not cause, how to differentiate between unilateral, peripheral, and central? Well, the answer for that is peripheral has atrophy, while central has very little atrophy. So guys, I hope you guys really like this video. Thank you guys for watching this video, and I hope to see you guys next time.